Hello, everyone. I'm Maria Theodulu. I am the Program Director of Breast Cancer Medicine at New York Oncology Hematology up in the Capital District. We have a series of podcasts that are addressing the issues that our patients who are diagnosed with breast cancer confront. Um, it's really a wonderful educational series that we have, and today we're going to talk about some of the cardiac effects that we can encounter, what we look for, what the high risks are, based on these newer and newer drugs that are really increasing survival. And we have a guest today that are increasing survival and making such wonderful strides in the oncology community, but we can never lose sight of what potential side effects there may be. So I would like to introduce Dr. Jeffrey Uzzilia, who is a cardiologist at Capital Cardiology Associates up in Albany and several satellite areas in the surrounding arena, going all the way up to Clifton Park, all the way over to Troy and the Catskills. Um, Jeff is also a cardio-oncologist. And maybe we can start off this whole program, Jeff, by you're saying hello and telling us what a cardio-oncologist is and why it's a new specialty right now.
All right. Well, great. Maria, thank you so much for having me. So, cardio-oncology is a relatively new field where cardiologists work in this kind of in between area where we're trying to help patients with cancer deal with things that are kind of effects of their treatment and also work in preventing those things down the road. Because, as you said, breast cancer is a perfect example. The oncology world has advanced so much, and the survivorship for breast cancer is so high that now you worry about any of the potential negative effects of those treatments from a heart perspective for decades and decades moving
Right,
forward.
those long-term side effects, right.
Yeah.
You know, in a specific arena with HER2 overexpressing breast cancer, where that was my area of research back in the early 1990s when I was at Memorial Sloan Kettering Cancer Center. That was basically a death sentence. And now it has such a huge survival and such incredible change of the natural history of this particular subtype of breast cancer because of all the new medications that we have. But unfortunately, we can't lose sight that they may have side effects. And there are chemotherapy drugs, there are antibodies, antibody drug conjugates. And I'd like to ask up front, who are the patients that we should consider more high risk for deleterious cardiac events from any of our potentially cardiotoxic drugs? Is there a patient population that we really should be looking at much more closely, following more closely from your perspective?
That's a great question. And, research has told us that the people that are more prone to have effects from these chemotherapy treatments or radiation treatments tend to kind of mirror what we see in traditional heart disease. People that have a family history of heart problems, risk factors like hypertension, diabetes, hyperlipidemia, an elevated BMI, people that are smoking, those people are at higher risk. And anybody who has any predisposition structurally with their heart is going to be a little bit higher risk for complications of those treatments. So in a way, it makes
With
things
those
easier because we're looking.
complications and say no treatment, or do we are we proactive in trying to minimize or mitigate those complications?
Yeah. So I think our goal is to allow you guys to do what you need to do. So somebody might be at higher risk, but we're really lucky now. We have a lot of tools. We have prediction models. We can kind of calculate risks. We can look at the heart with the use of computers and kind of get an idea of who's going to be at higher risk to develop problems. And on top of that, we have treatments that will hopefully prevent problems or at the very least mitigate those problems. I think we're lucky that we have a lot of tools that we didn't have in the past.
So I meet a patient, Jeff, and I know that in order to get her disease under control, and in most cases with potential cure, um, I send patients to you, and whether they are in their 60s or they're in their 40s, and we're seeing also very young patients in their 20s and early 30s. What do you The patient comes into your office. I've already told you that I'm going to use a drug that has potential cardiac toxicity. How do you start that workup?
Yeah. So first of all, I just want to say this population of patients is just a joy to work with. They're just amazing people, and it's one of the best parts of our jobs. So I think we look at it two different ways. I think there's the traditional cardiology aspect of things, and in general, women tend to be underdiagnosed, undertreated. Their risk factors are not as well controlled. So I think there's that aspect of every female patient where we say, are we doing the best we can to modify their risk factors in terms of their overall risk for heart disease in general, separate from their cancer? Um, then on top of that, we look at the therapy that you're giving. And a lot of times I'll have the conversation with the patient and say that, there's a potential that this could affect your heart. Let's look at the things that we can do to lower your risk of that happening. And sometimes I'm a little bit optimistic when I see, a patient comes in and their blood pressure is a little bit higher, or there's some things that we could kind of address up front. Little higher blood pressure allows us to use some of these protective medicines,
Mhm.
things like ACE inhibitors and beta blockers that we may not be able to use. Some of your population, the very young patients that you were talking about, the 20-year-olds, their blood pressure is really low, and it kind of limits some of the things that we do, and we have to be a little bit more creative in those settings.
Sure. And, from my perspective, during that initial visit, when we're outlining a treatment protocol, a treatment strategy, patients ask me, "Why are you sending me to a cardiologist? Why an echocardiogram?" And I tell them, "Well, you don't know, and your mom may not know, and I certainly don't know if you were exposed to rheumatic fever when you were a child and it was subclinical. We don't know if there's a family history that could be translating a cardiac risk to you, and just to be safe and establish a baseline." And it's always interesting to me that in some of my young patients, I find that they are have an elevated cholesterol, and then I hear, oh, it runs in my family. So what do we do there? What is an echocardiogram? How is it different from an EKG? Let's talk to this audience that we have now that we're speaking to.
Yeah, so that's another great question. So an EKG is kind of a snapshot of your heart, the heart rhythm at the time. An echocardiogram is actually a series of images that we get with ultrasound. Uh, Extremely helpful. It can give us information about the lining of the heart muscle itself, the valves. We can tell if the overall heart function is strong or maybe not quite as strong, and that will help guide our treatment, particularly in light of the medications that they're going to receive from you.
And when we send a patient for an echocardiogram, and there are some medications that I just get a baseline echo, and then I don't have to repeat it from my perspective. But there are some medications where I need to continue to monitor the heart every 12 weeks or so, especially with these anti-HER2 new antibody treatments. What are you looking for with these serial echocardiograms? What are you reporting to me where I may have to pause treatment or think about an intervention that I need guidance from you?
So specifically with the HER2 new therapies, keeping an eye on the heart throughout treatment is really important. We have some newer technology, something called strain imaging. And strain imaging is using the computer to look at the heart and see how little parts of the heart muscle move relative to each other. It's a technology that's more advanced than what our eyes can see. And by following that pattern over time, we can predict who's more likely to develop weakening of the heart failure or weakening of the heart muscle. And if that happens, that could eventually lead to congestive heart failure.
Mhm.
So by following not only the strength of the heart, the contraction pattern visually, we use the computer to get these strain images. And that combination is usually what I report back to you and the other oncologists, usually with recommendations, either everything looks great and we don't really have to modify therapy, or we're starting to see some changes here. Let's see if we can initiate some medicine to kind of protect the heart here. And hopefully we can avoid any interruptions in treatment, because we want the patient to, obviously get the top of the line treatment for their cancer.
Thank you, Jeff. And let's just switch the hat that you're wearing right now from cardio oncology to cardiology. And really, I'm the reason for these podcasts, and a lot of them are going to deal with nutrition and well care. Others are going to deal with sexual health. This one is dealing with, keeping the heart healthy. What do you say to your patients? I mean, I want my patients to be proactive. I want them to minimize the toxicities to the heart from poor lifestyle choices, whether it is a um, poor nutrition, not optimal nutrition. We always push for plan forward, whether it's alcohol intake. Can you speak to us a little bit about what everyone should be looking at to keep their heart healthy?
Yeah, that's another great question. I think it's something we underemphasize because we're always focused on, medications and things like that. But a lot of the things that you focus on with your patients are things that we focus on in terms of primary prevention for heart disease in general. So most of our patients, we want them exercising at least 30 minutes a day, most days of the week, usually at least five. We obviously don't want anybody smoking. Want to be very, very careful with alcohol. Beyond that, I think patients should be aware of their blood pressure, aware of their sugar. They should be aware of their cholesterol levels. And on top of that, especially if there's a family history, they should be up to date in terms of screening for things. There's, specific populations where we'll do screening tests on the heart, things like a calcium score that'll give us an idea. Is there any plaque there that we should know about? Sometimes people have absolutely no risk factors for heart disease other than a family history. And a lot of times that family history is really, really important, but it doesn't come up when we do calculations of risk for heart disease. And it's always important to keep that in mind.
And I have sent patients to you that are brittle diabetics, that have a history of a family history as well as a personal history of hypertension, hyperlipidemia.
Mhm.
They've been diagnosed with a cancer that I have optimal treatments for, but I want to treat them safely and optimally. I tell them to see you, to see their cardiologist, especially in a group that focuses on cardio-oncology, um, to optimize their health, decrease those risks, so I can move forward with treatment. Have you looked at all at compliance and how often? Because I'm not the only one who refers to you. Clearly, there are multitudes of medical oncologists who refer to you and your group. Patients who are on immunotherapy, other drugs that have toxicities, with other types of liquid and solid tumors. Do you find that patients are compliant? Do they come back when you ask them to come back? Has anybody looked at that? I'm just curious.
We try to keep pretty close track of our patients.
Mhm.
This population, our cardio-oncology population, is a little bit smaller. We don't allow our schedule to get overbooked because we feel like those patients need a little bit of extra time. So if we notice that those patients aren't coming in, we're reaching out and making sure they come back because it's
It's interesting. Patients will cancel my appointment, but they never cancel yours. You know, sometimes they'll say, "Oh, do I really have to come in? Can we just talk by phone?" And then I'll hear on the phone, "Well, I have an appointment with Dr. Uzzilia or one of his, mates, and I have to keep that one." So I think my breast population is pretty compliant when it comes to follow up. We certainly in the breast cancer arena, and I think we're seeing it now in the colon cancer and other malignancies. Obesity is such a deleterious risk factor. We've been trying to educate patients. There are well documented scientific studies that have looked at obesity and inflammation in the breast and some of the sequela from a high BMI. And I will say a low BMI is also not healthy, but just talking to what's in the media right now and all the things that we are trying to get hold of to educate our patients. You have a nutrition clinic that you're running, that has a dietitian, and you talk about some of the semaglutides, some of the injectables. Can you talk to us a little bit about that? Because we're thrilled in the breast cancer arena. We feel that it is decreasing the risk of a breast cancer recurrence by decreasing that BMI if it's excessive.
Yeah, yeah, we've been fortunate to start a metabolic center, and we
Mhm.
try to include a little bit of everything in there. So we have dietitians working with patients. Our clinical pharmacists are helping us with pharmacologic weight loss, where people are on GLP-1 type medications, sometimes non-GLP-1 medications. There's people that prefer not to do injectable therapies. The clinical pharmacists that work in that metabolic center also work with us in cardio-oncology. So a lot of times, if there is an overlap there, we'll be like, maybe we should incorporate the metabolic program in this as well. We're always going to start with the basics of, how much are you exercising? What does your diet look like? I know one of your conferences that I attended, we were able to talk to our nutrition expert from NYU and had a long discussion about this, how important that kind of being kind of plant forward, maybe not plant based in total, but how much.
Right. Neil Iyengar, who is at the very forefront of the metabolic program
Mm,
uh, and obesity program, inflammatory program at Memorial Sloan Kettering Cancer Center, whose research has been published and he's presented at every national and international symposium,
mm,
uh, really has guided us in moving forward, and with a lot of different pathways that have extended because of his research. And we're hoping actually to bring a program like his up to the Albany Capital District area, a virtual program which will guide patients regarding exercise, mental health, nutrition, and so on, complementing what you're doing, which cannot be virtual. It has to be live, really.
mm.
Um,
Yeah,
so
we have.
I'm looking forward to really a promising multidisciplinary advancement in cardiac health, and with all of the umbrellas around cardiac health, perhaps helping to decrease some of the oncologic issues that we have by way of occurrence, recurrence, and sequela of therapies. Jeff, if you were to tell this audience, and clearly there are going to be survivors in this audience, there are going to be patients who are dealing with advanced disease, who are undergoing therapy presently for their early breast cancer, family members, or just, an audience that wants to be educated about their well care. When would you say that we should start evaluating our cardiac health? We're going along, we're working, we're having families. At what point in time do we formally make an appointment with a cardiologist?
You know, that's a great question. I think it's always important to think about the primary prevention aspect of things all through adulthood. Doesn't mean that you have to see a cardiologist, but through the primary care, making sure that blood pressure, sugar, exercise, diet, uh, cholesterol, all those things are at least looked at periodically. I think people that have multiple risk factors, obviously anybody with symptoms that could be cardiac in nature, or a family history. I think those patients should be seen on the earlier side. I'd much rather see people before things have developed than see them in the
Right,
emergency room when they're having an event.
right, right. And um, last question. Okay, last question. Um, what about those patients who or persons, you
Mhm.
know, that are looking at their health and are wondering about their nutrition and whether they're doing the right things for their heart? You mentioned a calcium score before. Can you just expand a little bit on what that is for the audience?
So, calcium score is a really, really helpful screening test. It's very simple, takes about a minute or two to do. So, normally, when you're doing a scan of the heart is beating. So as it's beating, the arteries are moving, and it's really difficult to get a picture of it. So what we do with the calcium score is we use EKG leads on the chest. We can figure out when the heart is still. We time a picture, take a very quick picture, and then we're done. So there's no IV contrast dye, there's no IV needed. And because we're only taking a picture at that one moment, we're only getting a tiny bit of X-ray in that picture. So it's not a full CAT scan or anything like that.
So
That
radiation exposure is minimal.
very, very minimal. Fortunately, these scanners are really, really good. And then with that information, we can actually see the heart arteries. So if cholesterol is building up inside the arteries, it mixes with inflammatory cells and forms a plaque. Over time, that plaque forms a layer of calcium. So we can't see cholesterol, but we can see the calcium on top of that. And then we use the computer and our eyes to get a score for how much plaque is in the arteries. That calcium score can go from 0 up into the hundreds and thousands, and it correlates directly with the amount of plaque that you have. The lower the score is, the better, and it does vary based on age and gender and ethnicity. So we use kind of a calculator to say, at age 70, how much plaque should you have? Are you above or below average in this setting?
Mhm. That's great. That's great, Jeff. I can't tell you how much I appreciate your joining me today. This podcast series has been made possible because of a wonderful grant that I received from one of my 23-year breast cancer survivors from Memorial Sloan Kettering Cancer Center. So I have to give a shout out to Stacy and her husband, Richard Rosenthal, who have supported these programs and educational programs with a generous grant year after year, allowing me to do the work that I did downstate, now upstate. Jeff, I'm probably going to be calling on you again. Very last question, I promise. Are these calcium scores ever reversible in patients who move forward with proactive treatment, changing their diet, and so on?
And it's a great question. It's a question that people ask all the time. I would say in general, we don't know of any way to eliminate the plaque that's already there. But if we can catch it early and help stabilize it, we're going to reduce the risk of things down the road. And those things are,
Right.
revascularization, stents,
Sure.
bypass events.
So you don't want to build any more plaque on plaque. I almost feel that everybody should be getting a baseline calcium score at some point in their life at middle age, just like we get breast imaging to rule out early problems. Jeff, thank you, thank you, thank you. I see that you're in your clinic. You have your stethoscope on. You're going to get back to patients, and I'm going to go look for my dog and see what mischief he's up to. Thank you again for being with me today. Bye, everyone.
Thank you.